All right, our next topic is hemostasis. And hemostasis is just a fast series of reactions for the stoppage of bleeding. It does require clotting factors and substances that are released by both platelets and damaged muscle and endothelial cells. There are 3 steps involved. You should know these steps. They are step 1, the vascular spasm, step 2, platelet plug formation, and step 3, coagulation. Coagulation or blood clotting is different from platelet plug formation. We'll see in step 3 that fibrin threads are added to a platelet plug, whereas a platelet plug does not immediately include fibrin threads. So let's look at step 1 in more detail, the vascular spasm. And this is when a blood vessel responds to an injury with constriction or vasoconstriction. A vascular spasm is triggered by a couple of things. There's direct injury to the blood vessel itself, including both its vascular smooth muscle and the inside lining of these blood vessels. The inside lining is made up of endothelial cells, and then inside the blood vessel are platelets. What also triggers vascular spasms are pain reflexes. Now, of course, vascular spasms are the most effective in smaller blood vessels because their constriction is going to more significantly reduce blood flow until the other mechanisms, or step 2 and 3 of hemostasis, can kick in. So platelets don't generally stick together because regular blood flow, intact endothelial cells, intact muscle cells, not having the outside collagen fibers of blood vessels visible to the inside of the blood vessels, all of that makes sure that platelets don't stick together. But in order to form a platelet plug, in order to plug a torn blood vessel, we need the platelets to stick together. And the stimulus or trigger for that is exposed collagen fibers. Exposed collagen fibers, which are located on the outside of a blood vessel, are not usually visible to the inside. And so platelets don't stick. But when these collagen fibers become exposed because the vessel is damaged, the platelets begin to stick to these collagen fibers. They actually use a factor called von Willebrand factor, which acts as a bridge to stabilize the platelet collagen fiber adhesion. Other things that occur during platelet plug formation is that prostacyclins and nitric oxide secreted by endothelial cells are not acting to prevent platelet sticking. They would be acting to prevent platelet sticking in an intact blood vessel, but they are going to be inhibited or not produced in excess or really much at all during the process of hemostasis. So when activated, platelets swell. Once they swell, they become spiked and sticky, and they begin releasing chemicals. And these chemicals are messengers. They include things like ADP and serotonin and thromboxane A. These things are procoagulants, but they're also going to encourage further vascular spasm and platelet aggregation. Platelet aggregation is definitely a positive feedback cycle. You may remember this from chapter 1 in your lecture textbook. You want to go back and look at positive and negative feedback cycles, that's where I would go. But hemostasis, especially platelet plug formation, does require this positive feedback cycle, which is essentially as more platelets stick to the exposed collagen fibers, they release chemicals, and that causes more platelets to stick, and then they release chemicals, and then so on and so forth. So we're going to see an amplifying effect in order to build this platelet plug. We're not going to turn off or reduce the effect because of an initial stimulus. That would be a negative feedback cycle. Instead, with a positive feedback cycle, we're going to get an amplification. And that's great for forming a platelet plug. We need more and more platelets to stick to plug this hole or tear in a blood vessel, and we need them to release their chemicals so that the platelets continue to do so. This positive feedback cycle is locally controlled and will end when the tear is plugged. So platelet plugs are fine for small vessel tears, but the larger breaks in vessels would need an additional step. So we would need to go on to step 3 in the larger blood vessels. Step 3 is coagulation. And during coagulation, which is also known as blood clotting, we're going to see the addition of fibrin threads to the platelet plug. These fibrin threads will reinforce that platelet plug and will make the blood clot and the platelet plug, so fibrin plus platelet plug, now called a blood clot, very effective in sealing the larger vessel breaks. So what the fibrin threads do is they transform from a liquid to a gel. And this is a pathway we'll have to look at for how they're going to transform, how we're going to create fibrin. It does begin with a series of reactions that use clotting factors, again called procoagulants, and many of these procoagulants are plasma proteins. These plasma proteins are numbered. They're numbered as factor 1 to 8, and they're just named after their order of discovery. Many of them are synthesized using vitamin K, which is a lipid-soluble vitamin, and we need other factors from the liver in order to synthesize vitamin K. We also need calcium, so there's nutrients required in order to make sure that we can create fibrin. And coagulation occurs in 3 phases, and we're going to look at those. But before we move forward, let's just review the events of hemostasis. So figure 16.13 in your textbook here, and what we're seeing in the image is event 1 is the vascular spasm. And that's a smooth muscle surrounding the vessel contracting, causing vasoconstriction after a tear. In event 2, we have platelet plug formation, where injury to the endothelium lining of the vessel exposes collagen fibers, and that causes platelets to adhere. And that was our positive feedback cycle. And then we also have not only the platelets then releasing chemicals during that positive feedback cycle and making nearby platelets sticky, but by the end of event 2, we had a platelet plug form. And then in event 3, which we're going to look at further coming up, we have coagulation, also known as blood clotting. And that's when fibrin proteins are forming a mesh and that traps red blood cells and platelets, forming a clot. So let's investigate that. So step 1, or phase 1, I should say, of coagulation is creating prothrombin activator. So prothrombin activator can be made by one of 2 pathways. The name of the pathways are intrinsic or extrinsic pathway, but usually both are active and contribute to the creation or activation of prothrombin activator. Phase 1 is triggered by tissue damaging events that damage both vascular smooth muscle and endothelial cells, and this involves a series of procoagulants. Again, we just talked about some procoagulants. If I go back to slides numbered factor 1 to 8, and those are going to be active during phase 1. And each pathway has a series of steps that cascades toward the formation of prothrombin activator. And prothrombin activator is going to require factor X, which complexes then with the calcium ion, and platelet factor 3. There's also some input from factor 5, and all of that is required in order to form prothrombin activator. But if I was just to summarize phase 1, either the intrinsic or extrinsic pathway of coagulation generates or produces prothrombin activator. They're both eventually going to lead to this production of that prothrombin activator. Let's just talk briefly more about the intrinsic versus the extrinsic pathway. Their names give you some clues as to why they're different. So the intrinsic pathway is called the intrinsic pathway because clotting factors required for the coagulation process are present within the blood. And they're generally triggered by negatively charged surfaces, such as that of activated platelets, exposed collagen because of damaged endothelial cells and vascular smooth muscle. Even glass of a test tube can trigger the intrinsic pathway. The extrinsic pathway does bypass several steps of the intrinsic pathway, so it's a much faster pathway, and it's called extrinsic because factors needed for the clotting are located outside of the blood vessel. A trigger for the extrinsic pathway is exposure to tissue factor, which again was also called factor 3. So those are procoagulants. In this image, we're seeing both the intrinsic pathway and the extrinsic pathway, as well as their series of steps that lead to the generation of factor X, which then complexes with calcium and factor V, as well as tissue factor 3, all in order to create prothrombin activator. So again, prothrombin activator consists of numerous complexes, beginning with factor X. Phase 2 is still of coagulation, is the pathway to thrombin. Prothrombin activator is going to be able to catalyze the transformation of prothrombin to thrombin. So this is a chemical reaction. We want thrombin, and we need prothrombin activator, which we just made. Doesn't matter if we use the intrinsic or extrinsic pathway. but we need prothrombin activator to convert this precursor to the enzyme thrombin. So the precursor is prothrombin. The active enzyme is thrombin. And now that we have prothrombin activator, we can form thrombin. This enzymatic action can occur. So this is phase 2 of blood clotting or coagulation, is generating thrombin from prothrombin. Then phase 3 of coagulation or blood clotting is actually generating fibrin in order to create or use the fibrin mesh. Now, the reason we needed thrombin was in order to convert fibrinogen to fibrin. So we want fibrin, but fibrin, when not being acted upon, exists in this precursor state called fibrinogen. Fibrinogen is soluble. What that means is it's dissolved in blood plasma. And we need the solid, kind of more gel-like fibrin threads. Because our fibrin strands, these fibrin threads, are the structural basis of a blood clot. So fibrin causes plasma to become that gel-like trap. So we're going to go from kind of a liquid plasma to a gel-like plasma because of the integration of these fibrin threads. But we can't do that if we don't have fibrin. So thankfully, after step 2, we should have thrombin, and it can convert fibrinogen to fibrin. And then thrombin is also going to require complexing with calcium and factor 8, which is fibrin stabilizing factor, and this will allow us to create the cross links that are going to be our fibrin threads. And fibrin and the platelet plug coming together will strengthen and stabilize the blood clot. Now, we've been talking a lot about procoagulants, and they're going to be pro-blood clotting or pro the coagulation stage. But also there exist anticoagulants, which are factors that normally dominate in blood to inhibit coagulation. So coagulation does not normally occur unless we have some of the triggering factors, such as nociceptors releasing chemicals, so that's a pain response, damaged endothelial cells, which release chemicals that then act on platelets, and even damaged vascular smooth muscle and the exposure of external collagen fibers. So here's that phase 3 step. Fibrinogen is soluble or dissolved in blood plasma. Fibrin is an insoluble polymer, kind of more solid and gel-like. And fibrin is turned from fibrinogen into fibrin thanks to thrombin. It does need to complex with calcium and factor 8 in order to form the cross-linked fibrin mesh that is more common and found interwoven around the platelet plug in order to stabilize that clot. So here is the entire pathway. I know it may be a small image. You may need to follow along in your textbook, but we have our intrinsic or extrinsic pathway that lead to the generation of factor X, which complexes with not only calcium, but also factor 5. And this can happen on a phospholipid surface. We saw if we're using the intrinsic pathway, it could even happen in a glass test tube, but we need to create prothrombin activator after the complex of factor X and its combination with these other factors. Our goal is the generation of prothrombin activator, and that is because we need to turn prothrombin into thrombin, which prothrombin activator does. Then we need thrombin to turn fibrinogen into fibrin because we need fibrin fibers in order to create a cross-linked mesh that stabilizes the blood clot, which is the ultimate goal of coagulation because coagulation is also known as blood clotting. So here in this image, you can see a scanning electron micrograph of red blood cells or erythrocytes trapped in the fibrin mesh. So these fibrin or insoluble fibers have kind of mixed with blood plasma and the red blood cells in order to create this fibrin mesh. And it would also be mixing with the platelet plug that was step 2 in hemostasis. And this is stabilizing a blood clot. I do recommend just kind of reviewing Table 16.3, you should have at least read through it. These are the blood clotting factors that we were calling coagulants, just all in one table for you. Again, many of them require vitamin K, a lipid-soluble vitamin, and are made, or their source is the liver. So liver disease or something going on with the hepatocytes of the liver can cause problems for the generation of blood clotting. There's still a couple of steps to occur, but these are not a part of hemostasis. They're kind of the cleanup steps, and that includes clot retraction and fibrinolysis. So the clot has to be stabilized even more. It eventually will have to be removed, that's fibrinolysis, and that will happen when damage has been repaired. So clot retraction is when myofilaments called actin and myosin, which are present in platelets. They're also present in different types of muscle, but when these myofilaments contract, usually in about 30 to 60 minutes after the clot has formed, that contraction is going to pull on those fibrin strands on that mesh, kind of make it much thicker and more compact. It'll squeeze any extra or liquid plasma from the clot, and that generally is called serum, because serum is plasma minus the clotting proteins. And all the clotting proteins right now are either stuck in that fibrin mesh or involved in the procoagulation steps of hemostasis. This would draw the ruptured blood vessel edges together when the clot retracts and kind of squeezes everything closer together. It does promote healing. When the vessel is healed, that's when fibrinolysis will occur, but vessel healing requires some growth factors like platelet-derived growth factor released by platelets and vascular endothelial growth factor, which is stimulated to repair the torn ends of the blood vessel, and this is generally going to be released by endothelial cells. And these growth factors stimulate the division of different types of tissue, like platelet-derived growth factor stimulates the division of smooth muscle cells and fibroblasts in order to rebuild the blood vessel wall, whereas vascular endothelial growth factor stimulates endothelial cells to multiply or perform mitosis in order to restore the endothelial lining. Again, endothelial cells are epithelial cells, and they're generally simple squamous epithelium. Fibrinolysis is a process whereby clots are removed after repair is completed, so it's kind of like a clot dissolving process, and it can begin as early as 2 days and continue for several days until the clot is dissolved. In order to perform fibrinolysis, we need plasmin. Plasmin is going to exist as a precursor called plasminogen, and plasminogen is a plasma protein that is trapped in the clot, must be converted to plasmin, which is our actual fibrin digesting enzyme. Tissue plasminogen activator is responsible for turning plasminogen into plasmin. But tissue plasminogen activator also works with factor VII and thrombin in order to complete this conversion process, in order to create this plasmin, a fibrin digesting enzyme. There's plenty of factors that limit the normal clot growth. Two mechanisms that limit clot size would be the fact that we swiftly remove and dilute all the clotting factors. We get rid of the procoagulants after hemostasis, after fibrinolysis. And once we have a repaired blood vessel, normal blood flow will quickly dilute these procoagulants. There's also inhibition of the activated clotting factors after coagulation, and there's very limited amounts of thrombin, and it's really restricted to this local area where the blood clot formed. So it's restricted to the clot by the fibrin threads. It's stuck in there, and that's really going to prevent the clot from getting too big or escaping into the bloodstream. Also, anticoagulants start to be active after fibrinolysis, sometimes even after coagulation. There's antithrombin 3, which inactivates any unbound thrombin that escapes into the bloodstream, and heparin, which is from basophils and mast cells that inhibits thrombin by enhancing antithrombin 3. So they work well together, heparin and antithrombin 3. Other factors include the prevention of platelet adhesion. And when we don't have a torn blood vessel, there's no reason for platelets to continue clinging. There's no reason for them to continue secreting their chemicals. So smooth endothelium of blood vessels, once repaired, prevents platelets from clinging. Then endothelial cells do secrete antithrombic substances, such as nitric oxide and prostacyclin. There's also vitamin E quinone, which reacts with oxygen and is a potent anticoagulant. So anticoagulants are helpful. Chemicals from endothelial cells and smooth muscle are going to help prevent not only platelet adhesion, but the production of anticoagulants instead of our procoagulants. And then we want to look quickly at just two major types of disorders, and then one that kind of involves both types of disorders. There are thromboembolic disorders of hemostasis and bleeding disorders of hemostasis. The thromboembolic disorders result in undesirable clot formation, whereas the bleeding disorders, you probably guessed it, they're going to prevent normal clot formation and result in undesirable bleeding. And then disseminated intravascular coagulation, or DIC, is an interesting disorder that involves both types of disorders. So first, let's look at the thromboembolic conditions. Thrombi and emboli can form, and a thrombus, or plural would be thrombi, is a clot that develops and persists in an unbroken blood vessel. So this is an attached blood clot. It could block circulation, it may lead to tissue death, but it may just be a small blood clot attached to an unbroken blood vessel wall. and blood can still kind of get around it, but it is dangerous because it can become an embolus. So an embolus is a thrombus that's broken off of that kind of unbroken blood vessel wall and is now freely floating throughout your bloodstream. The reason this is dangerous is because it can cause an embolism. This blood clot can get lodged in a small blood vessel and not get through, and that obstructs the vessel. An example of what can happen is tissue death in very vital organs like the lungs or the brain. An example of that would again be pulmonary or cerebral emboli. So an emboli is what occurs when an embolism obstructs a vessel. And risk factors for the development of an embolism are atherosclerosis or plaque buildup in your arteries, inflammation, slowly flowing blood or blood in stasis, so kind of stagnant, and that could be from immobility. So sitting at a desk all the time is not great. You do need to stand up every couple of hours, if not every hour, just to get blood flowing so that your blood's not stagnant and that hopefully we can prevent an embolism. Certain people, again, are at higher risk for developing that, but it doesn't hurt to get some regular exercise. Thromboembolic conditions are going to be treated generally with anticoagulant drugs, so used to prevent undesirable clotting. Makes sense. You've probably heard of aspirin and heparin and warfarin. The last two you've probably seen commercials for. They are used clinically for pre- and postoperative cardiac care as well as prevent venous thrombosis, mainly heparin there. Warfarin is an oral anticoagulant. It does reduce the risk for stroke patients, and especially those who are prone to atrial fibrillation, where blood pools in the heart. Now, it's important to mention that warfarin does interfere with the action of vitamin K, so it's not usually meant to be taken long term, whereas aspirin is available over the counter, and it's an antiprostaglandin that inhibits thromboxane A. So it kind of inhibits some of that kind of platelet plug formation or blood clotting, but not to a dangerous extent. It mainly is going to help us lower heart attack incidence by 50%. So it's going to inhibit kind of unnecessary blood clot formation. So bleeding disorders include thrombocytopenia, which is a deficient number of circulating platelets, petechiae, which are kind of small hemorrhages, could appear, and these are spontaneous, widespread hemorrhages, but they're small. And due to suppression or destruction of red bone marrow, you could develop these petechiae. So examples are malignancy, so cancer of the bone marrow, radiation, drugs, these could cause petechiae. And petechiae, again, small hemorrhages, kind of like dots or kind of little red dots. You find them oftentimes kind of on the face or the hands, sometimes the feet. And we would say that someone's probably suffering from thrombocytopenia if their platelet count is less than 50,000 per microliter. That would be diagnostic. And treatments would be transfusion of concentrated platelets. So here's an example of petechiae, kind of these little dots. They're just small hemorrhages from blood vessels. A lot of bleeding disorders are due to impaired liver function because, again, we need vitamin K. And vitamin K is a lipid-soluble hormone whose source tends to be the liver. So vitamin K deficiencies, hepatitis, cirrhosis, all of those tend to lead to or can cause or be indicative of bleeding disorders. So impaired liver function leads to the inability to synthesize the procoagulants that need vitamin K. And liver disease can also prevent the liver from producing bile. And bile is needed to absorb fat and vitamin K because it's a lipid-soluble vitamin. Another bleeding disorder that's generally genetic is hemophilia. Hemophilia includes several similar hereditary bleeding disorders. The most common is going to be, you see here, hemophilia A, 77% of all cases, and that would be due to a problem with clotting factor 8. Hemophilia B was actually a problem in Queen Victoria's family because she had a particular mutation that affected clotting factor 9, which means that her affected descendants had hemophilia B. And this was dangerous because it was an issue because she had children that wound up scattered throughout other European royal families, and they had children and they brought the gene with them. And some of their kids ended up having hemophilia B. The symptoms of hemophilia include prolonged bleeding, sometimes petechiae, especially into joint cavities, you would have bleeding. The treatment now is injections of genetically engineered factors, but kind of back in the day, that was not something that we had. But we have kind of eliminated the need for plasma transfusions and risk of contracting hepatitis or HIV from these blood transfusions or plasma transfusions. So injections of genetically engineered factors for the ones that are missing, generally used nowadays to treat hemophilia. And then last but not least, we'll look at disseminated intravascular coagulation, or DIC, which involves both widespread clotting and severe bleeding, both. And the widespread clotting occurs in the intact blood vessels, blocking blood flow, and the clotting is so widespread that it uses up all the clotting factors, and the blood that's left doesn't have the clotting factors, therefore severe bleeding results. It follows because the residual blood isn't able to clot because those clotting factors were being depleted or used up because of the initial widespread blood clotting. This can occur in cases of blood poisoning called septicemia, incompatible blood transfusions, or as a complication in pregnancy. All right, so that's it for this video. Next, we're going to look at blood transfusions. So make sure to check out that video as well.